All right, happy Friday, everybody. We are just getting here to the clinic. It's just before 7:30. Two procedures today. We have first patient with some low back, some neck pain, and then also some anterior fascia stuff over the pecs. And then our second patient is some chronic ankle pain who this patient has struggled for quite some time. He's coming in from out of state, and so we're going to do our physical exam today and then determine what we are going to treat. But that is our Friday. I hope you enjoy this week here at RP. All right, everybody, so we just finished up a good day here at Fridays at RP. Well, we're at RP, but this is Fridays at RP. It's currently just after 6 o'clock, so definitely a full busy day. We ended up having 3 cases total today, so I'll walk you through kind of each of our cases, talking about them a little bit to try and give you some insight on maybe why we did things or what we did. So first case was a patient who has been suffering with chronic low back pain, started probably after her first pregnancy, which was about 15 years ago. Storyline is a little unclear on that part, but she's been having chronic low back pain for about 15 years, and then chronic headaches and kind of not full migraines. They call them migraines, but not the classic migraine or photophobia symptoms, but these tension-like headaches that start in the back and then wrap around to the front. And those have been going on for quite some time as well. And so our approach today, our physical exam showed that the main structures in her lower back that were contributing to her pain were her sacroiliac joints, which is a very, very commonly underdiagnosed cause of low back pain. So we treated both sacroiliac joints as well as the supporting ligaments around these sacroiliac joints. The reason we do that is because a lot of the times it's not just the actual sacroiliac joint that is causing pain or contributing to pain, but also the stabilizing ligaments around it. And so we treated those, and then 2 groups of nerves that we treated in her low back, the middle cluneal nerves, and then the dorsal or the medial cutaneous branch off of the dorsal rami. We approached that with a fascial/nerve hydrodissection. So under ultrasound for our middle cluneal nerves, we basically have here our lateral edge of the sacrum. The cluneal nerves are going to come off the dorsal root here, and then just at about this area here, so just past the lateral edge of the sacrum, we actually do a fascial hydrodissection, open up the planes that are deep to the glutes, and we actually get to bathe the middle cluneal nerves, and we get all the little branches and all the major branches of it. And then we did an erector spinae plane hydrodissection to treat the medial cutaneous branch of the dorsal rami. So I know we've talked about that one before, but here we have, so our spine, right here is our SPs, here's our transverse processes. So what we do here is under ultrasound, we actually come and advance our needle up to the transverse process. We place our needle tip on it, and then we do our injection. What that does is it opens up the fascial plane that's deep to the erector spinae group, and that's going to bathe a lot of the medial cutaneous branches of the dorsal rami before they pass through the erector spinae group. And so the way we think about this is doing perineural injections for the erector spinae group over top for those same nerves is like watering the leaves on a tree. You can do that, and that can be beneficial. However, we like to try to water things a little bit further down. And so this is more like watering the trunk. So we're able to treat more things in a smaller amount of time and less needle pokes. And then for the neck, so a lot of the times tension headaches, if they're not originating from the facet joints, which hers were not, her facet joints on physical exam were actually normal and non-painful. But a lot of the times we can get the nuchal ligament and the suboccipital muscles, as they're attaching up onto the base of the occiput, can become painful. There's a lot of nerves that pass through that region. So we have the third occipital nerve, we have the greater occipital nerve, and then we have the lesser occipital nerve. On palpation and testing, her greater occipital nerve was really, really tender. So we were suspecting that she had an entrapment neuropathy of the greater occipital nerve as it was piercing through the fascia, the nuchal fascia, upper cervical region. And so we did a nerve hydrodissection of the greater occipital nerve at the level of C2, and then also at the level of the occiput, in conjunction with injecting up onto the base of the occiput in order to help the muscles and fascia that are attaching on there to be less painful. And then lastly with her, as part of rounding out her whole treatment, we actually hydrodissected the anterior fascial plane over the sternum because our assessment had shown us that she was a little bit rounded in and folded down anteriorly. And so we wanted to open that up more. And so we hydrodissected that, then did a little bit of manual work over that to try and open up that fascia, which we were hoping would help her diaphragmatic breathing, because she's also been having issues with that. So that was our first case. Our second case of the day was a patient who came in having some ankle pain. Now, he had a pretty severe fracture of the ankle several years ago after a basketball injury. And ever since then, he's had a little bit of chronic pain and some limitation in his range of motion. And so in talking with him today, you know, we discussed our different options based on our physical exam, which was going to be treating the nerves in the area, the fascial planes, and then also trying to address some of the osteoarthritic changes that have occurred because of the original injury and because of the surgery. If we look at his MRI, he had diffuse degeneration throughout a lot of the joints, but mainly in the talocrural joint, which is the ankle joint proper. And that was because part of his original fracture, he actually tore part of the interosseous membrane between the tibia and the fibula, and that really can damage that talocrural joint. And so we did a very high concentration of PRP into the talocrural joint. Then we also hydrodissected out the superficial peroneal nerve, which provides sensory information to the front side of the ankle, which is where he was having all of his pain, as well as the intermediate and medial cutaneous branches off of that superficial peroneal nerve or superficial fibular nerve, depending on which way you call it. And that was all with PRP and PPP. And then our last case was actually an add-on. One of our patients who has been struggling with headaches and migraines came in for an IV because a headache that has not really gone away over the last 2 weeks. And so we discussed some different options with her. Now, we are currently in the process of working her up for a potential CSF leak, so spontaneous intracranial hypotension. But in our midst of doing that workup, we are still looking for options to try and help her. And so one of the things that we found beneficial in some of our patients who have some cervical stenosis that's mild, which she does, and that we're potentially suspecting a CSF leak, is actually to do a cervical erector spinae plane hydrodissection. We've had a few cases now where we've kind of used that as a bridge while we're working these patients up to try and help them, and it appears to be helping them symptomatically. We've only been doing this probably for about the last 8 to 10 weeks. And so we still need more time behind our therapies that we're trying here, but it seems to be a good approach to help manage pain in some of these patients where other therapies, whether it's oral steroids, injectable steroids, are not really helping because they've tried those. What we do here, now this is a little more technical than the lumbar erector spinae plane hydrodissection, where we're coming in off of the TP here. In the cervical region, our TPs are a lot smaller, and we have an anterior and a posterior tubercle. So what we do here is, again, under ultrasound guidance, we are going to come up to the posterior tubercle of the TP, and then we are going to do our fascial plane hydrodissection deep to that erector spinae group. That is going to, again, help bathe the nerves that are coming off of the dorsal root, which is going to be mainly our medial cutaneous branch of the dorsal rami. And so we're hoping that that helps kind of get her out of this acute headache flare that she's in while we start to or continue on our workup for a CSF leak. So that was our Friday. So if you made it all the way to the end here, thank you so much for watching. I really enjoy this series. It's great to be able to share what we do a little bit more behind the scenes. So if you made it all the way in here, please just drop a comment and say, hey.